Thank you for joining our second webinar of the year. I am Natalie Studdert from CF Queensland support team. CF Queensland has invited Angela Madison from the Prince Charles Adult CF Centre to discuss CF-related diabetes. Please note that you have been muted. If you have any questions or comments, please type them in the questions box and we will have them answer them after the PowerPoint presentation. If you have anything further to discuss and would like more information, please contact the Prince Charles CF team. Please sit back now and enjoy the presentation, and I'll hand you over to Angela.
Thanks, Natalie. I'd like to thank CFQ for inviting me to present the webinar today. The topic that I'm going to discuss today is cystic fibrosis-related diabetes. Feel free to submit any questions that you have as we go through the presentation. If it's a particularly relevant question, I will stop and go through that question at the time. But if most of the questions, we can probably wait and address them at the end of the presentation, because sometimes I may get to discussing a point a little bit later on within the topic itself. So, what is cystic fibrosis-related diabetes? Just click on the first slide down, please, Natalie. Just bear with us for a second. Here we go. Thank you. I'll do that one. So what is cystic fibrosis-related diabetes? Well, it's a type of diabetes that affects individuals with CF. These individuals tend to be those with pancreatic insufficiency, so anyone requiring digestive enzymes. The whole diabetes is a very big spectrum, part of what we call abnormal glucose tolerance. There are actually quite a few patients that have truly normal glucose tolerance, and abnormal glucose tolerance develops as patients increase in age. The overall prevalence that we have noted from quite a few studies around the globe are that we have about 10% in the 5 to 9 age group, and this increases dramatically to around 50% in those patients in over 30 years that we tend to see through the adult centre. At the adult centre at the Prince Charles Hospital, we've reviewed our prevalence every 3 years since the year 2000, and our prevalence has stayed quite steady at around 26% of some sort of abnormal glucose tolerance over our whole group of patients. It really just depends on the centre. There are some other centres throughout the world who do see prevalence rates much higher, around the 50% mark. So it really depends on the patient group and the patient population that we're looking at. So what causes CF-related diabetes? Well, the thick and dehydrated pancreatic secretions that occur as part of the basic defect in the CFTR gene. These very thick dehydrated pancreatic secretions, we know that they block and destroy the cells that make the digestive enzymes, the Ackner cells, and this blockage leads to scarring of the pancreatic cells, and that's why the majority, not all, but the majority of patients need to use some type of pancreatic enzyme replacement therapy, enzymes to help digest food. And that this scarring in the majority of patients is present from birth. But there's another type of cell that the pancreas is responsible for producing a hormone, and this is insulin. So over a longer period of time, the same scarring process leads to destruction of the pancreatic insulin-producing cells, which are the beta cells. It's a different cell that makes the digestive enzymes. So digestive enzymes tend to be destroyed quite early on from birth, but the beta cells producing insulin tends to take a little bit longer for the scarring and the destruction to take place. So that's why we see a lot more of CFRD or CF-related diabetes in the older population, because of the longer time period for the destruction of the insulin-producing cells. But over time there is a gradual decline in insulin production, and we do see insulin deficiency, not completely, but gradually over time. It tends to occur in, as I say, people who need pancreatic digestive enzymes and what we classify as pancreatic insufficiency. So there are also a group of patients who don't need to use pancreatic enzymes to digest food, and this is called pancreatic sufficiency. And we don't tend to see true CF-related diabetes in this group of patients. Occasionally it can occur, and occasionally it can be a slightly different form of diabetes, not CF-related diabetes, which we're discussing today. So is CF-related diabetes the same as type 1 diabetes or type 2 diabetes? And those are the main two types of diabetes that we hear about through the media and through general aspects of health, because the rates of especially type 2 diabetes is increasing dramatically in the overall population. But CF-related diabetes is a distinct form of diabetes. It is different from type 1 and type 2 diabetes, and therefore its management is different. People with CF do not make enough insulin, and this is a result, as I said before, of this scarring in the pancreas. So type 1 diabetes, which used to be called insulin-dependent or juvenile onset diabetes, occurs mostly in childhood, and people with type 1 diabetes can't make any insulin, so they must take insulin to survive, which is why it's often referred to as insulin-dependent. People with type 1 diabetes are dependent on taking insulin and would get very sick and would have a life-threatening complication called ketoacidosis if they don't take insulin. Type 2 diabetes, which is non-insulin dependent diabetes or adult onset diabetes, this is a different cause. It's more a lack of a normal response to insulin, in addition to the body not making enough insulin. And this type of diabetes tends to occur more so in adults, and more so in adults who are overweight. So people with type 2 diabetes sometimes need insulin, but mainly are treated with a tablet. Most are told to lose weight and can control their diabetes through a healthy low-fat diet, sometimes with tablets, but mostly diet and exercise. Sometimes they need tablets added in to help the pancreas secrete more insulin, or to help the cells uptake insulin better. And sometimes in late stage of type 2 diabetes, insulin is also used. But CFRD, as I say, is different. It's an insulin deficiency. It's not a complete loss of insulin, and it's not through purely the same mechanisms that work in type 2. So, as I've mentioned before, the main cause of CF-related diabetes is insulin deficiency. But there are also other causes of CFRD, just to complicate things a little bit more. There is an increase in cortisol, or this is a stress hormone, which is another reason that CF-related diabetes can occur. Now, your stress hormones, they tend to be produced with any type of infection. So especially in CF, what we see is an increase in glucose levels at times of chest infections. But cortisol can also increase with other types of stress, psychological stress, emotional stress, as well as physical stress on the body. And steroid treatment that, again, also is used at times of infection in CF can also increase your cortisol level. And this increase in cortisol causes insulin resistance. Now, insulin resistance is really just your body resisting the way insulin is trying to work, and therefore your body cannot use your insulin normally. And insulin resistance, when it occurs because of stress or infection, can be temporary. And when that stress or infection resolves, you go back to where you started, whatever your baseline of glucose tolerance is. So this is where it gets a little complicated, because people with CF tend to have some type of insulin deficiency, but when we add insulin resistance on top of that, that can really lead to a high level of glucose that needs to be treated. So what does insulin normally do? Well, when we eat food, food is broken down into little packages of nutrients. And those main 3 macronutrients that food is broken down into is a very small form of fats, proteins, and carbohydrate. And the purest, most simplest form of carbohydrate is glucose. So your 3 macronutrients are the fat, protein, and carbs. And then there's also vitamins and minerals. Now, insulin is a hormone, and when your body breaks down food and your blood glucose levels start to rise, insulin is produced in response to that. And insulin usually helps the body in its normal function is to move those little packages of protein, fat, and glucose out of the blood and into the cells. And it's when those nutrients are in the cells, that's where they start to do all their normal body functions. If they're just sitting in the blood and they can't get into the cells, then your blood glucose levels will rise, and you'll start to feel a bit more unwell. Let's have a look at that in a bit more detail. Oops. Just waiting for the slide to click over onto the next slide. There we go, thank you. So what causes insulin deficiency in CF? Just to recap, people with CF have insulin deficiency because of the scarring in the pancreas. And most people with CF make less insulin than normal, though not all people with CF go on to develop diabetes. But there's this underlying lack of insulin, so everyone has potential, but we can't predict who will go on to develop diabetes and who won't. So many people with CF have both insulin deficiency and insulin resistance. And this is why more people with CF get diabetes or CF-related diabetes than people without CF. So I'm just having a little trouble moving this slide up onto the next one. Just bear with me a sec. So even when people with CF are not acutely unwell, they do have chronic and underlying infections which can cause insulin resistance. So as I mentioned before, we've got 2 things happening: insulin deficiency and insulin resistance. Okay, so why do you actually need insulin? Well, the insulin allows, as I say, most of the nutrients, the proteins, fats, and carbohydrates, but especially the glucose, to move out of the blood and into the cells, to give the cells fuel, and to go about their daily activities, to renew cells, to give us energy, to walk, to breathe, to do all the bodily functions. We need glucose into the cells. Now, when there's not enough insulin because of the insulin deficiency, what happens is that glucose builds up in the blood and the levels rise. And when they rise quite high, it starts to spill over into the urine, and this loss of glucose in the urine can make people with diabetes go to the toilet a lot and have an increased thirst. And these are the classic signs of all types of diabetes, but it always, in CF, these symptoms don't always occur. They're more pronounced in very high levels of glucose, and if your glucose levels are just a little bit raised, you might not realize that you've got these symptoms. So insulin allows the body cells to take up building blocks of protein and build muscle tissue. So without enough insulin, what we find is that protein breaks down and that we actually end up with muscle loss. And this is actually the more important in people with CF, because if we lead someone to having muscle loss, this will affect breathing because lung function depends on muscle strength. Insulin allows the body to use and to store fat, so without enough insulin the body's fat stores are drained and weight loss occurs. So because people with CF make less insulin, which can lead to CFRD, it needs to be treated, and it needs to be treated with injections of insulin to replace the insulin deficiency and to help the body cells take that glucose out of the bloodstream and into the cells for energy, and also to spare the protein and the fat so that there's not any more weight loss, and so that lung function can function as best as possible as well. So how common is CF-related diabetes? It's very common in people with CF, and especially as people get older. Most of the larger studies that have been done at multi-centres throughout Europe and through the Minnesota Centre in the States have shown that on average we have around 35% prevalence in adults aged 20 to 29, and as I say, up to 50% in those over 30. But there are other types of glucose abnormalities in CF as well. I'm not going to go into all of those today, but I will answer any questions that people have. The other types of glucose abnormalities tend to be reactive hypoglycemia, and this tends to occur before we see high levels. We can also see low levels of blood glucose, and this can occur even when people are not on any treatment for diabetes. So we tend to find that people are reporting low levels of blood glucose levels, and I'll go into that generally a little bit later when we talk about hypotreatment. And there's also impaired glucose tolerance, where you may have slightly elevated blood glucose levels, not high enough to be classified as being diabetic or CF-related diabetes, but a little bit on the high side, and that to us is a bit of a warning. And when we pick up high levels throughout patients coming into hospital or through outpatients, we tend to ask patients to start doing a bit of monitoring to get a feel for what their glucose levels are in relation to their home diet, home exercise, to just see how high the blood glucose levels are going. Let's click on that again. I think it's not moving across anywhere. Oh. Just bear with me a sec. Up one. Up one. Slide 14 moved across. Just bear with us, we're just trying to move the presentation along to the next slide. Okay, sorry, we've just had a bit of technical difficulty. You might see that on a slightly smaller screen. Okay, so now just looking at how CFRD is actually diagnosed. It can be diagnosed in a few different ways, and the diagnosis that we work on is based on the American Diabetes Association General Diabetes Standards. So diagnosis can be either through a fasting level greater than 7 millimoles, or a 2-hour oral glucose tolerance test glucose greater than 11.1 millimoles at the 2-hour level, HbA1c greater than 6.5%, although we don't tend to rely on HbA1c in people with CF. It tends to be a little bit more on the lower side because of an increased turnover of red blood cells, or a random glucose level greater than 11.1, as well as very strong evidence of symptoms. But the diagnosis tends to be on 2 levels on different days. So that's diagnosis. How we look at diagnosing people is based on what we call a screening program. So Dr. Antoinette Moran and the American Consensus Guidelines actually have given recommendations on screening, which is that screening is carried out in all patients with CF greater than 10 years of age. Now these are guidelines, and it's up to individual centres to produce their own work-related guidelines. So I'm not sure what happens in most of the paediatric centres are screening, and certainly in our adult facility we screen patients. Screening is recommended by a few different ways. There's no sort of one global agreement on the best way to screen at the moment. So some people may have an oral glucose tolerance test, and this is recommended annually, but at a time of clinical stability. So there should be a 6 weeks clearance from infective exacerbation. And an oral glucose tolerance test is drinking a 75 gram of carbohydrate soft drink. It's a very sweet drink, and blood glucose levels are taken regularly up to 2 hours to look at how the body is dealing with that glucose load. Another way that CFRD can be screened for is using serial glucose measurements, and this tends to happen in our hospital when patients come into hospital, whereas we look at doing some serial measurements over 48 hours, and we do some before and after meal levels to see what the glucose levels are rising to. Another way of screening is if patients are using an overnight continuous feed. There should be some levels checked during and at the end of the feed. Because this is such a high bolus of carbohydrate over the period of having the overnight feed, either nasogastrically or through a button or a gastrostomy tube, we do recommend taking some blood glucose levels either at home or during an inpatient admission, just to check what the glucose levels are rising to mid-feed, because in some patients a very high load of carbohydrate all at once may need a little bit of insulin to help it be absorbed. And the last category are women with CF who are pregnant. So women with CF are at a higher risk of gestational diabetes, and in women without CF there's no GTT or a screening for gestational diabetes in the second trimester of pregnancy. And because women with CF are at a higher risk, we advise screening in the first and second trimester, and then also to have some screening after pregnancy. So what do we do if we're trying to avoid it? If they don't look, they won't find it. Should I try to avoid CF-related diabetes for as long as possible? Well, probably not. It is important to screen for diabetes because early treatment is the best prevention. If we can identify blood glucose elevation early, we can start insulin treatment soon. If insulin treatment is left too late, what we find because of the increase in blood glucose levels and the insulin deficiency, we tend to find weight loss, deterioration in lung function, and then a higher risk of long-term diabetic complications. So weight loss and decrease in lung function has actually been shown to occur quite a few years before people are diagnosed with CF. So these days we are really trying to start treatment as early as we can, and there are a few studies happening within Australia looking at early intervention, and we'll know results of those in the next few years. So what we're trying to do is screen everyone and look at optimal treatment as much as possible. So what happens if my screening shows that I have got high blood glucose levels? Well, we tend to not start insulin straight away. We tend to follow up with some home blood glucose monitoring, so teaching patients how to use a glucometer and testing levels throughout the day so that we get a feel for what's happening in response to your usual activity pattern and eating pattern at home. So it's important to write down your activity and your eating of different foods, and so that the team can have a little look at what your normal intake is and what your normal carbohydrate intake is throughout the day. And sometimes, depending on the patient's level of activity and what their pattern of food intake is throughout the day, sometimes we can hold off on treatment, especially if it's linked with temporary rise of glucose levels because of insulin resistance. And sometimes we need to discuss what types of treatment may be suitable. So how is it treated? Well, some people can control blood glucose levels by taking tablets, but in CFRD, most people are treated with injections of insulin, and this is the only medically recommended treatment for CF-related diabetes. Tablets tend to be used in type 2 diabetes, but not in CF-related diabetes. Insulin cannot be taken by mouth because it's destroyed in the stomach, so it needs to be given by an injection. And there's lots of different types of insulins and different actions of insulins, so there's no one solution for everybody. So we all probably know at least someone in the family, or a family member or a friend who takes tablets for diabetes. So it's often a common question, well, you know, my gran or my father uses tablets, so why can't I? Well, it's a different type of diabetes. Many people with CFRD wish they could treat their diabetes with tablets, but these tablets are not as effective as insulin in treating CFRD because it doesn't address the basic defect of insulin deficiency. And insulin is the only medical recommended treatment at this time. So I'm not going to go into lots of detail on all the different insulins, but I will summarise some of the types of insulins used. So there are many types of insulin, and the type and the time that it is given, those need to be matched to your eating and activity and your sleeping pattern. It's important that you give your CF or your diabetes care team as much information as you can about your usual habits, because this will determine what type of insulin is tried. And the best glucose control can be achieved if your insulin injections fit your routine. And that's why we ask patients to fill out some diaries of their food intake. We're not just being a pain and asking for lots of extra records and information. What we're actually trying to do is work out your usual carbohydrate pattern through the day and try to find an insulin that's going to match that, that intake as much as possible. So there's lots of different types of insulin, and I've broken these up into 5 different categories here. So first of all, we've got the ultra short-acting insulins, which are really fast-acting. They're basically for meal cover, and they mimic what your normal pancreas would do when you eat a meal and it bursts out a little shot of very, very short-acting insulin. So think of it as the 100-meter sprint, really fast-acting, and it's all starts and finishes very quickly. Then we move on to short-acting. These type of insulins last longer than the ultra short-acting, so more of a 400-meter run. They're short, they last for a short amount of time. And then we've got intermediate insulins, which take a little bit longer to start working, and they last longer. So more of a, maybe not so much of a sprint, but more of a jog. They take longer to work, and as I say, they last longer. Then we've got longer acting. Think of it more as a 20-kilometer walk. So really taking your time, very slow and steady type of insulin, and it works for a long period of time as a background insulin over the whole day. So normally the body produces 2 types of insulins. We do always have usually a long-acting background, very small amount of insulin, and then every time we eat we have the body normally produces very short bursts of insulin. And then for pre-made insulins, there's also some mixed ones that are a mix of ultra short-acting and long-acting, which basically mean that you can have one injection, but it's got 2 types of insulins there. And what we try to do with insulin is really help to match the person's usual intake, but we also have to take into account how ready people are to start insulin. And sometimes we have to start people on a very simple insulin regime. It may not be the best one to cover their food intake and cover their levels, but sometimes if insulin does need to be started and someone's not psychologically ready to add in all these extra treatments, sometimes we need to keep the regime a little bit more just as a band-aid measure initially to get people started. So bolus insulin is either the short-acting or the ultra short-acting for meal cover. And this is a type of insulin that we would script for patients needing to cover the rise in blood glucose levels that happens when you eat. So for example, if you measure your blood glucose level before dinner and it's 6.8, if we have you on 4 units of short-acting or 8 units of ultra short-acting, we know we've got the correct dose is if you're having your meat and your veg and your potatoes and your ice cream and your strawberries afterwards. So if we've given you the correct dose of insulin for that meal, your blood glucose level should come back to 6.8 2 hours after eating. And that's a good way to measure and see the effect of a short-acting or an ultra short-acting insulin. And the other type that I talked about was this very slow and steady, more of the walk, the background basal insulin, which is the slow steady release that helps keep your blood glucose levels within an even range even when you don't eat food. Now many people with CFRD, because they're only insulin deficient and don't have a complete lack of insulin, they tend to make a little bit of this insulin, and they make enough basal insulin that we don't need to add it in. So we do have quite a lot of people just using the short meal cover insulin. But if we find that your fasting levels or before breakfast level of glucose is creeping up a little bit high, then the team would discuss with you adding in a background insulin as well, just to try and help keep your levels within normal range. And the other type of insulin that we use, as well as the meal cover and as well as the background, is a correction dose of insulin. And this is an extra dose of insulin, especially helpful at times of sickness or infection, where you've got extra insulin resistance on board and your levels are higher than normal. To add in some extra insulin to help cover that. We do use some ultra short-acting insulin to correct a high level usually before meals, but correction doses can be given up to 3 hourly. And your healthcare team can assist you with a correction dose plan or a sick day plan based on your individual requirements and your insulin requirements. So just to recap, how to summarize the different types of insulins that are used to help treat CF-related diabetes. We've got bolus insulin for meal cover, basal insulin for background cover if it's needed, and a correction dose insulin to correct a high level. And as I say, correction doses tend to be used if you're doing something a bit more out of the ordinary, or if you're treating an infection and you need extra insulin. If you're finding that you're needing to use a lot of correction, have a chat with your healthcare team, and especially your endocrinologist and your diabetes educator, because what they'll actually do is look at how much correction you're needing and then total that all up and split it back and add it through into your bolus insulin if it's a more ongoing need for correction dose. So do keep in touch and get some help with that if you're finding you're needing a lot of correction insulin. So how is insulin taken? As I said before, it is an injection, and it can be injected into the tummy, the thigh, the buttocks and the upper arm. Now we do tend to favour using the tummy because of the slow, steady uptake of insulin. And the injection can be given usually around a couple of inches away from the belly button, but right out in an arc around the tummy area and right out to the sides. So whatever site that your healthcare team have suggested you use, make sure that if you need to take insulin that you stick to the same site. So say for example they've suggested tummy, just vary the injection site. Don't always go to the same area, because we want to avoid lumps and bumps from injections. Now the injections themselves, the needles are very tiny, and if you're slim and don't carry much body fat, I would suggest talking to your team about using a very small needle. A size 4 or a size 6 is the most common that we would use in our group of patients. So check your insulins in date. Once you open an insulin pen fill, you can keep it in your pen cartridge for 1 month. So it's important just to jot down somewhere in a diary or on a sticker on your insulin pen itself what was the date that you opened it, and even if there's insulin left there at the end of the month, chuck it out and replace. Any unopened insulin can be kept in the fridge, but once it's opened it does need to be discarded after a month. I would suggest that you change your needle after every injection. Needles are available free through NDSS National Diabetes Subsidy Scheme, and I'll mention that a little bit later. But changing your needle, because they're very, very tiny, constant use of a needle will damage your skin. So you won't be able to see the bend in the needle with the naked eye because they're so fine, but do change your needle after every injection. And with your injection technique, if you're not sure that you're using the right technique, just ask your healthcare team for some advice on that. But injecting straight in, just under the skin, do a nice slow injection, hold it in for 10 seconds and straight out, so that you're making sure you're getting all of that insulin. As I said before, rotating the injection site within the same area, and using smaller needles. A size 4 or a size 6 is more comfortable if you don't have much body fat. Because if we are injecting too deep into a muscle, it will change how the insulin works. It tends to be work a bit quicker, and we want a nice, slow, steady uptake of the insulin. At the moment, insulin pumps and consumables are not subsidised for CFRD in Australia. We do have a few patients who actually have type 1 diabetes diagnosed in childhood, and the levels confirmed with blood tests. So those patients are eligible for insulin pumps if it's a true type 1 diabetic rather than CFRD, because type 1s have a true total insulin deficiency. So this is the link here to the National Diabetes Subsidy Scheme, and a diabetes educator or an endocrinologist can help provide specific education. Any member of your healthcare team can register you with the National Diabetes Subsidy Scheme, and this entitles you to free insulin needles, but also free subsidised cost of glucometer test strips. So we would still register our patients even if they had abnormal glucose tolerance, and even if they weren't necessarily using insulin, if they were just needing to monitor glucose levels, or if they needed to monitor more in times of sickness because of insulin resistance. Even if they had impaired glucose tolerance or reactive hypoglycemia and they weren't using insulin, we would still register patients under CF-related diabetes or CF-related abnormal glucose tolerance, so that patients have access to the subsidised glucometer test strips. This website that I've got linked to here is a good one to jot down. It's got a lot of information about what is available and subsidised in Australia. So I'll just move on to some information on the diet side of things. So one of the frequent questions that I get when we're looking at abnormal glucose tolerance is, do I need a diabetic diet? The answer is probably no. What we do tend to do is give people individualized advice based on their specific nutritional requirements. The diabetic diet, which is normally associated with especially type 2 diabetes, is more of a low-fat weight loss diet, which is usually not recommended. We try to, in the majority of cases, as I say, give individualized advice, and for most people you still need a high energy diet. We need to look at your overall body mass index, and if it's low, there is no need to be restricting your food intake at all. A high energy diet can still be advised with insulin dosage tailored to your individual requirements. So most of the time, as I say, a high energy diet can be easily adjusted to using different insulin regimes. And there's all different ways to do this. If people are using a fixed insulin regime, it is still important to sort of spread your carbs out through the day, but have a nice high protein and fat component of your intake. But a nice flexible ratio can be given if people are willing to try and look at a more flexible insulin regime. And by that, it does mean a little bit more education, and it does mean learning to recognize what a carbohydrate food is, recognize the amount of carbohydrate, and use carb counting. And once people are able to do that, then we can give an adjustment, what we call an insulin to carb ratio. So that very short-acting insulin is actually adjusted to your carbohydrate quantity, which gives complete flexibility over what you eat and how much insulin you inject. And this is the best way to optimize your glucose levels and try to control them within normal range. But it's not for everyone. It's a bit more of an intensive education program to learn about carb counting and adjusting your insulin. So it's something that can wait. It's not something, sometimes we educate people straight away on this technique, but it's not for everyone. Sometimes it's a bit overwhelming at first, and people need to just grasp the whole concept of using some type of insulin, and then this carb counting and carb to insulin ratio can wait till a little bit later. So just to recap, most people still need to eat their usual high calorie, high protein, high fat diet to help achieve and maintain a normal, healthy weight. And as I said before, this is where it gets a little bit confusing because it's the opposite advice given to type 2 diabetes. But keeping your blood glucose level at a near normal level will help to maintain or improve your weight and your lung function. And people with CF tend to need more energy, fat and salt in the diet compared with people with type 2 diabetes. So talk to your healthcare team because it is a slightly different approach. So just to recap the two things that I mentioned before, where if you're on a fixed insulin dose, so the same doses each day, then using regular meals and regular snacks with a similar amount of carbohydrate is one approach to help control glucose levels. And then a more intensive insulin to carb ratio, looking at flexibility, can be taught at a later stage, which is using very short-acting insulin to cover meals, but adjusting that short insulin to your carbohydrate intake, and also using a basal or a background insulin. Okay, so I'm not going to go into too much detail with exercise. Exercise is recommended generally for people with CF to facilitate good lung strength and function and airway clearance. But discussing with your CF physio and your diabetes team about your individual adjustment to insulin and diet is also important. So we will quite often have a chat jointly with the physio and our patients in clinic about what their insulin requirements are, what their exercise is, and look at either a decrease in insulin before exercise or extra carb to cover the exercise. Exercise tends to make your blood glucose levels rise initially and then fall later in the day, and the fall or the hypo related to exercise can occur for quite a while after exercise, so it is important that we adjust insulin to match your activity level and adjust your carbohydrates as well. So what happens when you're sick? Because I've mentioned before about the difficulty with insulin resistance when the body's stressed and there's an increase in cortisol level and your body's insulin doesn't work as well as it should. So extra insulin requirements are usually needed, and usually 3 to 4 times more insulin is needed when you're sick. So what we suggest is that whatever your usual insulin prescription is, that you keep taking it even if you can't eat. You need to monitor your glucose levels more frequently, but because insulin doesn't work as well when the body's stressed, you'd still need to keep taking insulin. Check your blood glucose level often to see if you actually need more insulin, and this is where your correction doses every 3 hours can come into place. And if you've got your own individual plan, use that and monitor. And if you're worried or if you're not sure, contact your team sooner rather than later. If you're not able to eat because of sickness, sip on some carbohydrate-containing drinks to replace the carbohydrate you normally eat. So just sipping on some normal juice or soft drink or flat lemonade, whatever you can tolerate when you're not feeling well. And having insulin when you're sick will actually prevent weight loss and help you to heal faster so that your blood glucose levels aren't going too high. Check your blood glucose levels and record the results so that you can discuss those with your team, either over the phone or if you can get to a clinic appointment. And discuss in advance with your healthcare team, what do I do when I become sick? It's important to have a sick day action plan so that you know what to do. So especially if your blood glucose levels are constantly over 15, they're running high, that's when you need to be discussing what extra insulin is needed and using lots of more sugar-free, so low joule cordials, lots of water to help hydrate you at that time to get your blood glucose levels down under 15. So every service is different. And every service has different links with diabetes services. So if your CF service has a CF-specific diabetes or endocrine service, please use it. Services operate differently, as I say. Most have an endocrinologist either working within the team or linked in through the diabetes service. A credentialed diabetes educator, a CF dietitian, all make up your team and can assist with your diabetes. So just to give you some idea of the overall blood glucose goals, and as I say, these are found in the Moran consensus paper on CFRD management. So HbA1c targets are less than 7%, pre-meal levels between 4 and 7 millimoles, and post-meal levels under 10 millimoles. Now that's a very general blood glucose goal. For some people the levels will be very tight and less than that depending on circumstances, and in some patients the levels will be higher than that depending on circumstances, but most of the time this is a good sort of overall goal for what your levels should be. So how do I fit all these extra treatments in? I can't manage to deal with thinking of food and exercise and insulin and injections and monitoring. It's very, very common for people with CF to feel completely overwhelmed when told about this additional diagnosis of CF-related diabetes. And it can take quite a long time to come on board with, as I say, adequate treatment. Talk to your team, keep in touch through your clinic. If you live further afield, you may be able to discuss with your team the option of some telehealths or email, telephone support. We certainly offer email follow-up, especially of any changes that are made to insulin treatments through the clinic. And as I say, different services have different sort of resources available. Within our clinic we have an endocrine review service every Monday, so that's certainly an option for patients attending the Prince Charles Hospital. But just talk to your team about what is available, and especially if you're struggling, because it is very, very common that it's a lot of extra treatment initially. So using extra insulin will make you feel better rather than just avoiding using it at all. Talk to others who've been through and dealt with CFRD. There's a lot of our patients who find it very difficult to start with, and then after a while will be able to talk about how they've dealt with it. Starting with a fixed dose of insulin may be the best one to go with if you're struggling, if you don't want to be learning about carb counting and matching insulin to your intake. Starting with a fixed insulin dose is a good start. But when you become more confident with insulin injections and with monitoring, when you do feel ready to move on and look at a bit more flexibility, talk to your team about that, because it's definitely the best option if you're feeling up to looking at a more flexible regime. So how do you actually check your glucose levels? Well, there's little glucose monitors, which you'll probably see if you've been in hospital and they've checked your random level on the ward. These little glucometers can be purchased or available on loan, and a diabetes educator can help to teach you how to use the meter correctly. And the manufacturers also have some very handy online tutorials if you get stuck or forget what function does what. Most people with diabetes are advised to check their glucose levels regularly. So especially initially, before breakfast, before lunch, before dinner, and before bedtime snacks, you might also be asked to check your glucose levels at different times, especially after meals, around 2 hours after meals, known as your postprandial glucose level. And what that's doing is we're not just asking you to prick fingers to be annoying, we're actually trying to look at how your glucose levels are responding and how your insulin dose is matching. So we're actually trying to adjust insulin based on glucose levels. And you might also be asked to check glucose midway through an overnight feed. So talk to your team about what the best way for your levels, because there's different ways to check depending on what insulin treatment you're on or what regimes you're on. It may be a little bit more individualized. So you can get to control your diabetes by knowing what your glucose levels are, and these little diaries are available to record your levels. Your meters can be downloaded as well, so that you can look at your levels over time, but quite often, especially initially once you're starting insulin, it's good to write it all down, and it's easier then for the team to actually go back over the last few weeks and look for patterns in your glucose levels, and that makes it easier to adjust insulin if we need to. Okay, so how do I prevent diabetic complications? Well, through your clinic, what things that we look at are an HbA1c, which is an average glucose level over the past 3 months. And we check that just to see what your average glucose level is. So 3 to 6 monthly, that should be checked through clinic. Blood pressure can be checked just to screen for any hypertension. Once a year to do an eye check to check the small blood vessels at the back of the eyes. A lipid test just to check what your blood lipid levels are. Most of these tend to be low, but once a year just to check a blood lipid profile. And after you've had diabetes for more than 5 years, we will just do a little spot urine check to look at your protein levels in the urine, and that's basically a screening for looking at the very small vessels in the kidneys to check that they're functioning properly. And the endocrine doctors will also do a little nerve test on your legs to check the nerve endings in your feet. So over time, there can be diabetes complications to the small blood vessels, and this is what we're trying to prevent through screening. So just moving on, we've only got about 5 more slides left. So looking at hypoglycemia, hypo meaning low, this is the most common complication of CFRD. It can occur in people with CFRD, so those especially on insulin are more prone to hypo, but it can also occur by itself. When I mentioned before about this abnormal glucose tolerance called reactive hypo. So what happens when the blood glucose levels drop too low, usually less than 3.9? It can be dangerous if you're taking insulin because there's a likelihood that your level will keep dropping. Whereas if you're not taking insulin, you tend to get a bit of a delayed response in the liver producing extra glucose. But it still can cause hypo symptoms and make you feel not too good at all. So early treatment prevents worse symptoms of a hypo. And when you're newly diagnosed with diabetes, yourself and the people that you live with need to learn how to treat a hypo properly. So some of the symptoms of low blood sugar are sudden hunger, upset tummy, shaky, dizzy, pale face, weak, confused, blurry vision, a change in the way you act or feel, fast heartbeat, and a tingling or a numbness around the lips and the mouth. And this sort of feelings that you may experience if your blood glucose level is dropping suddenly or dropping below 3.9. So the treatment, what we suggest if you're having a low or a hypo, you need to have some very quick acting type of carb very quickly. Just enough 15 grams of carbs, which is 3 to 4 glucose tablets, or 5 to 7 jelly beans, or half a cup of soft drink or juice, or a tablespoon of sugar or honey. Just one of those. Don't over-treat the hypo, but get in enough to treat the hypo. If you can, check your blood glucose level, and then if you can, 10 minutes later, just try to stop what you're doing, especially if you're driving, pull the car over, and wait and check your blood glucose level. If it's increasing after the 10 minutes, that's fine. You're going to have to follow that up with a slower acting carbohydrate. But if it's not increasing, if it's staying low, or if it's decreasing, you need to have another 15 grams of carb. When your blood glucose level does start to increase, have something a little bit more sustaining. So a glass of milk or a sandwich, a yogurt or a piece of fruit. It's got a bit longer. If you're taking insulin, you do need to always carry some type of glucose tablet or jelly beans with you so that you can treat it quickly. Now, if your blood glucose level is extremely low, so low that you pass out or you physically can't drink, someone else does need to give you a glucagon shot or call 000. Most of the time you'll get early warning symptoms, and it's important not to avoid those, but to stop what you're doing, sit down and treat it to avoid a situation where it gets too low. But if your blood glucose level is dropping, you might not be thinking quite as clearly or quite as straight, and that's why it's important for people around you to start doing the treatment for you. It's important to let them aware in advance that that could be a possibility. So just to recap, I'll go through some of the main points of the talk this morning. CF-related diabetes is a common expected complication of CF, and its diagnosis and also its treatment are very different to type 1 and type 2 diabetes. Most people with CF still require a high energy diet, and insulin needs to be matched to that high energy diet. Register with the National Diabetes Subsidy Scheme, which offers you subsidised cost of strips for monitoring and needles if injections are required. Learn to self-manage as best that you can. Good control will help your nutrition and your lung function. And seek help from your CF team if you're struggling to cope with the extra treatment and the extra monitoring. Thank you for listening to the webinar today. As I said, I'd like to acknowledge the CF team at the Prince Charles Hospital and to the staff and the many patients that I've worked with over the last 14 years that have taught me more than I'm sure I've taught them on diabetes. And I'd like to thank CFQ again for inviting me to present the webinar today. And I'd like to just suggest that if you're needing more information, one of the links that you can get to through the CFF Foundation in America has got a very comprehensive patient and health professional handbook, which was updated in 2010, and it's the last slide on the slideshow there that I can't get to at the moment. There we go. So there's a link on there which you can probably get through Googling, but as I say, it is through the CF Foundation in America. It's a very comprehensive handbook that the Australasian guidelines have also been based on. And it's a very comprehensive manual, but any sort of background information you can certainly get through your own individual care teams. Thank you. So anyway, we can pull up those questions.
There's just one here. It says, some people think that CF-related diabetes is caused by the high-fat diet, CF diet. Is this correct?
So the question that we had come through over the internet there was that there is a thought that some people think that a high-fat CF diet causes CF-related diabetes. No, that's not correct. As I've mentioned in the talk there today, the main cause of CF-related diabetes is insulin deficiency caused by the ongoing fibrosing and scarring in the pancreas that damages the beta cells that produce insulin, and that this is the primary deficiency.
We might leave it there, Angela. Thank you very much for coming in and discussing this with us today. If anybody else has any more questions, I'll follow up. Please feel free to email me or contact the CF team at Prince Charles Hospital. Thank you.